So this talks about catheter placement and management. So less than 10% of chronic maintenance for hemodialysis should be maintained through catheters as a permanent choice for access. I think it's very important that with the patients you have a conversation with them about catheters and the benefits and also mostly the disadvantages. There are patients that like having catheters. There's no needles involved. It's not painful. So sometimes you've got to convince them that they should have the fistula done sooner. And it's important to tell them why that's necessary. So the types and locations for tunnel catheters, there's essentially temporary catheters, which are Shiley catheters that you put in. Ideally, you want to get them out as soon as possible. If you know they're going to be on dialysis for more than a few weeks, you want to convert that to a tunnel catheter as soon as possible. In some patients, if they've burned up most of their central access, the catheter might be the only way to get them on dialysis. So if that's the case, there are other options. You can convert to a hero catheter, but if you don't have that capacity, then a catheter is what it is. And obviously, catheters with rapid flow rates are preferred. So this is the main difference between a temporary and a tunneled, is just the tunnel catheter has that cuff, moves the exit side of the catheter away from the venous puncture site, so it theoretically reduces the risk of infection, and it also kind of anchors the catheter in place from being pulled out as easily. So there is no proven advantage over one cuffed catheter over another. Some people like a split tip, some people like the palindrome. I guess it's just a preference thing for most people. So we saw this picture before. You leave the catheter in long enough, especially on that left side, it can eventually cause a nominate vein inclusion, and you burn that access. So this is one of the things that patients don't really know about, and you got to educate them on, is that you leave these catheters in a long time. You're not only going to lose the catheter site, but you're also going to lose the whole left arm for potential access in the future. And sometimes, obviously, they don't know that. It's your job to kind of inform them of that. So again, educate your patients on the use of catheters, how to keep them clean, prevent infections, and then to really have a conversation about making a plan to remove that catheter as soon as possible. So I think for most people, like we said with the anatomy, the right side is the preferred side just because it gives you a straight shot. Femoral is probably the least preferred due to the risk of infection. So venous access, I've always used an ultrasound. Every vein, every artery, always use an ultrasound. And one of our mentors, Dr. Peden, would always tell you, you got to see the needle tip go into the center of the vein, not just kind of have a blind idea where the vein is and kind of put a needle towards it. You want to really see that needle go into the vein to avoid complications. And then I'm sure you guys know you can use a needle without a syringe. I almost never put a needle on the syringe. For guidance, in most cases, if you can, try to get the wire into the vena cava for more support. One of the things that is you're getting less ectopy and arrhythmias while you're working, and it gives you a long, straight support channel to get the catheter in without complication. Keep the wire loose. Common thing you see is when you're teaching interns how to put these catheters in, you're seeing the wire and the catheter tip kind of slide together. And under fluoro, when you watch that happen, you see the wire kind of buckle, and now you just create like a real big spear tip. And if you're not careful, that can really perforate and do some bad stuff. And then the catheter tip, you want to get the catheter in pretty far. A lot of times when you get a catheter that's not working, it's because the tip just isn't in far enough. So you want to get the tracheobronchial border at the least. The azygos vein, you gotta, if you have an aberrant anatomy and you can't seem to cross the innominate, sometimes you get fooled. You think it's in far enough, but you aspirate back and it's not working. Take some contrast, take a picture, and you might not be where you think you are. So like this catheter, you'd assume that there might be just some tortuous anatomy. Catheter is just not really working so well. Put a wire down, try to guide it down farther, take a picture and see what's going on. I think we saw this picture on the last slide. So this is the catheter wire going down through the hemazygos off the left side. This is the other picture you guys saw. So if the catheter tip makes it into the SVC and it works, I guess you can leave this. But if there's no other access and this is the only way to get into the central circulation, then it is what it is. They need access and you have to give it to them. So this is just the anatomy of how that looks. So for femoral catheters, the catheters need to be long enough to reach the straight portion of the IVC. For short-term catheters, if you don't have longer Shiley catheters, use the longest one you got, and hopefully it's long enough that it's going to work just for the time being. And hopefully, as soon as whatever the reason is that you put a femoral catheter in resolves, you can put a more proper catheter in. Again, also the way you tunnel the catheter is important to prevent any kinks. So I tend to stick as low as possible on the clavicle and then tunnel out laterally to kind of make you a nice smooth transition on the tunnel. For catheter exchange, let's say the catheter is not working, there's some problem. Obviously for an infection, you don't necessarily want to do this, but you can put 2 stiff glide wires in, 1 through each port, cut the cuff free, slip the old catheter out through the exit site over the wires, and just shove a new catheter in without having to do a new stick or cut the catheter and trying to lose wire access. But it's got to be in for about 2 weeks before that tunnel track is mature enough for them to tolerate this. So these are just some pictures of a SVC occlusion. You can get a wire down, balloon enough, just to get a channel through so you can get your catheter in. It's the same thing. So for infection, I know at Methodist, you guys still have that protocol where just because you had a catheter infection, we didn't always remove the catheters. Depending on what the organism was, if it was just an exite infection, in some cases you can just treat with antibiotics and local care to see if you can salvage that catheter, not have to remove the whole catheter and lose that access site. But I think it's important to talk to your infectious disease doctors at wherever you are, and also the team, because obviously if they're not going to use the catheter and they're going to make you take it out, sometimes you can try to educate them on, hey, not every catheter needs to be removed for a local infection. But I'm in private practice, and if I try to suggest this, I usually get a lot of resistance, and I ultimately always end up taking the catheter out. But something to think about is that there are protocols that you don't have to always take the catheter out. So the more you do, the better you're going to get. You're going to learn tricks along the way on how to get catheters in safer and more effectively and more efficiently.